Once again, good morning and thanks for joining us. In a moment, we're going to share how Essex Council tackled health inequalities through workplace prevention, what was commissioned, how it's delivered, and what CC's wider data tells us about why workplace health checks work. Just to begin with a little bit of housekeeping, the session's going to be around 50 to 60 minutes long. If you could keep yourself muted, feel free to add any questions that you have to the Q&A as we go. Where the questions are fairly simple to answer, we'll also pick those up as we go, but some of the meatier questions we'll leave to the end for the panel. Just to remind everybody, the session's being recorded and we will share slides afterwards. If you have any technical issues, try rejoining or flag in the chat. So onto the agenda. I'll give a very short introduction to the CC platform in a few moments. We have Charles Adeyemi from Essex County Council Public Health, who will cover the commissioning perspective and later summarise the programme's findings. We also have Lynn Moforth and Abby Constable from Provide CIC, who will share the delivery story. What's worked, what didn't. I'm hoping that's a very short segment. I'll close with what our wider data tells us about how employees engage with prevention at work, and we'll finish with the Q&A. I'm just going to start off with a couple of minutes of context, the problem we're all trying to solve, and the platform Essex used to solve it. So it's always very difficult to summarise just how much is going on at the moment, because it feels like there's new policy coming out every week at the moment. But the 10-year health plan sets out 3 shifts, as we all know: hospital to community, including the neighbourhood health service with care built around everyday life, and that's including the places that people work. Analog to digital, with the NHS app as the front door, a single patient record, and connected data feeding population health insight. And finally, sickness to prevention, so looking at NHS health checks to include digital delivery, the new CVD modern service framework, which was published this month, and the core 20+5 focusing effort on the most deprived 20%. And of course, in relation to what we're talking about today, we have running underneath all 3 is the work and health agenda. So Get Britain Working, the DWP funded Work Well programme, and the Keep Britain Working review, which puts employers at the centre of tackling economic inactivity. A healthier workforce obviously is an engine of productivity. And the Essex pilot sits exactly where these converge: early detection for working age adults delivered where they already are. So risk, as we know, is often found late. Through the CC platform, we know, and we've seen specifically in Essex, that around 69% of our users hadn't had a blood pressure check in the previous 12 months. Mostly winning people facing a system that demands time, effort, and navigation. The response is to design around real-world constraints. So walk-up access counters digital exclusion, plain language feedback supports low health literacy, and familiar local settings, particularly including the workplace, builds trust, and a locally configured signposting and triage respects pathway variation. CEC's role is to make that design deliverable, workplace-based delivery at scale, a flexible local operating model, effective engagement of employers and working age populations. And that provides consistent usable data for employees, employers, and public health. And in Essex, that meant co-designing with local public health and delivering inside routine and manual workplaces, which is exactly what Charles, Lynn, and Abby will show you shortly. Just very quickly, just like to give you a very short overview of the CC platform, which will give you a little bit of context ahead of the presentation from the team. So the CC Max, which is depicted in, I guess, the first box, is a Class 2A self-service health kiosk. It measures height, weight, BMI, body composition, heart rate, and blood pressure. And it's got a number of different configurable risk assessments, from Q risk, diabetes, PSS4 for mental health, GAD2, WHO5, and a number of others. And we have several surveys coming online, which we've currently have in development For instance, we have a sort of live MSK survey, which will be coming on in the next few weeks as well. What we know from what we've done with Essex, but also at a wider level, employers really value being able to rotate the surveys, keeps the experience fresh and generates new insight for them to look at where they might need to strategically invest as well. The second component is the CC Mini, which delivers almost everything the Max does. The only exception is a digital height measurement. And this fits in a small case, which can go in the back of the car and sort of supports flexible outreach. And again, Lynn and Abby will come back to this a little bit later. Third component is CC Connect, which routes users to an onward service. And that could be anything from a light touch signposting to a locally available service, perhaps at a pharmacy, through to opt-in referral pathways that can share results with the provider, and that's Lynn and Abby in this case, or to a GP. And then within seconds of completing the health check, results will appear in the CC Health app or the online web portal, where users can understand what the results mean. They can enroll in behaviour change programs, and there's some pretty interesting gamification in there as well. So people can look at, if they make some changes to their health metrics, what that will mean for their risk levels. And finally, the last part that we provide is the CISO Insights, which gives benchmarked analytics to the employer, the provider, and the commissioner, again, Essex in this case. And Charles will talk about the value of that data a little bit later. So that's the context. I'm now going to hand over to Charles.
Brilliant, fantastic. Thank you ever so much, Jed, for providing that background and context to really set the scene. I'm just going to share my screen. Brilliant, fantastic. If I can just have a few thumbs up to just confirm that you can see my screen. Brilliant. My name is Charles Adeyemi. I'm a Specialist Wellbeing and Public Health Officer at Essex County Council with a specialised focus on health checks, CVD and men's health. And I'm delighted to be joined by my colleagues at Essex Working Well today, Lynn Mulforth and Abby Constable, and we'll be presenting the key highlights and findings from our recently published Workplace Health Checks Prevention Programme Evaluation Report. The report is available via Essex Open Data in two formats: a full report that provides details of the evaluation in more depth, and a shorter PowerPoint presentation, which we will be presenting today. So in terms of an introduction, so ourselves, Essex County Council Public Health, in partnership with Essex Working Well, launched the Mobile Digital Health Checks programme in March 2025. And this programme provides our routine and manual businesses across Essex with a free installation and placement of the CISU digital health check stations. So we acquired 2 health check stations, just as Jez highlighted, the Maxi, a standalone station as shown with the gentleman in the photo, and the Mini station, a smaller, more mobile station. And the stations enable staff to self-administer and complete a health check within 4 to 6 minutes and are available 24 hours per day, making them accessible to shift workers and those working long and irregular hours. So users undertake various health checks such as blood pressure, BMI, body composition, their smoking status, and we also opted for the additional clinically approved health assessments in Q risk-free and PSS4. So once I've undertaken my health check, where high risk is identified and consent is provided, individuals are referred into our county-wide health and wellbeing lifestyle service, the Essex Wellbeing Service, for support for smoking cessation, weight management services, blood pressure support, and other health and lifestyle services. And this approach supports our commitment to becoming smoke-free by 2030 and contributes to earlier identification and management of CVD risk. In terms of placements and installations, they range from 1 day to 2 weeks, and in some instances, this was extended. So I'm just going to provide a bit more background and context. So evidence consistently demonstrates that people in routine and manual occupations are less likely to engage with preventative health services, but experience a disproportionate burden to ill health. Factors include those long working hours that I mentioned, irregular shift patterns, and limited access to traditional health services. In March 2025, last year, alongside launching the pilot program, our tobacco needs assessment identified a 5.5-year gap in life expectancy between routine and manual workers and those in professional and managerial occupation. Smoking prevalence among routine and manual workers is 3 times higher than among other professional groups, with over 1 in 5 adults within these occupations in Essex currently smoking, exceeding our national and regional averages. And research has shown that opportunistic health checks delivered outside primary care settings are more effective at engaging men, working age adults, and people living in more deprived areas. So workplace-based delivery has shown to reduce barriers related to time, accessibility, and health-seeking behavior, making it a critical setting for prevention. And this program, of course, is in alignment with our overall well-being, public health, and communities business plan priorities around prevention, health inequalities, and wider determinants to health. So in terms of our aims for the program, this program was really driven by the commitment to reduce the prevalence of cardiovascular disease across Essex by tackling barriers up to preventative care. This was done by prioritizing early intervention and expanding access beyond our traditional clinical settings. The aim was really to reach individuals who currently sit outside of our standard NHS health checks delivery model, specifically our routine and manual workforces, through those opportunistic screening and targeted support. This program seeks to bridge the gap in health inequalities, ensuring that work-life constraints do not dictate health outcomes. And it was envisioned that this approach would create environments and conditions that foster a healthier, more proactive population that invests not only in the well-being of our residents, but also the long-term resilience and productivity of the Essex economy. So in terms of our objectives, these were based on 6 key pillars. So improving access to health checks across Essex, in terms of inclusion, so including those people and groups who currently sit outside of the NHS health checks criteria to be identified earlier. In terms of barriers, like I mentioned, in terms of those barriers, in terms of in time and accessibility, support for our routine and manual workforces, and in terms of the target cohort, our routine and manual workforces were the target cohort. And lastly, in terms of identification and support those who would not normally have access to health improvement services. In terms of our program outcomes, we wanted to empower routine and manual workers to access early intervention and preventative services, reduce those health inequalities within routine and manual workers, help routine and manual workers to improve their knowledge of health risk factors, so that health literacy, improve health outcomes within routine and manual workers, and as I mentioned, the overall contribution to a more productive and resilient Essex economy. I'm just going to go through the pilot's geographical and sector reach. So the pilot was initially launched in the districts of Basildon and Brentwood. Then we later expanded to other districts in June 2025. During the pilot phase, the digital health check stations were placed within 30 businesses and workplaces, including an additional placements of 11 business events. 52% of businesses engaged were new to the team at Essex working well, with the remaining 48% having existing relationships with our colleagues at working well. 63% of installations were in businesses that had a significant number of routine and manual staff employed. Types of workers using the digital health checks were from a broad spectrum of routine and manual occupations, as highlighted within the box on the slides. And the program showed strong performance in terms of equitable reach. The Essex population distribution across the 10 IMD deciles was plotted against the distribution found in digital health check users, and there was over-representation in more deprived deciles was seen with the digital health check uptake, which was consistently higher than the Essex population share in more deprived deciles, particularly in deciles 2 and 5. This indicates to us that the program was disproportionately engaging people from more deprived communities, many of whom are more likely to be employed in routine and manual occupation, where access to preventative health services is typically lower. In terms of key findings and metrics for the pilot, we recorded 1,654 health checks. In terms of male engagement, this was 55%, capturing a much larger proportion of men than our standard health checks. Just over 30% of users were aged under 40. So this was an additional younger user representation that added additional preventative value. 23.3% of all checks were outside of GP hours. This is a key strength of the program, was the ability to improve access to preventative health services beyond, as I mentioned earlier, those traditional models and available access outside of the traditional hours. It showed that the service is successfully reaching individuals who may face barriers due to work patterns, shift work, or care and responsibilities. And this is particularly important for routine and manual workers who are less likely to attend GP appointment during standard working hours, and highest levels of at 55.6 outside GP hours. We had a 19.3% prevalence in high blood pressure, which was higher than the both national and Essex prevalence rate at the time. I'm just going to move on to the next slide. So just to point out some really key perspectives, some key lessons, some key success factors. The first of which I'll highlight is making efficient use of the existing resources that we had as a commissioner. So embedding the program into our existing trusted workplace health program with Working Well, where there's already a strong foundation of workplace relationships, expertise, rather than creating a separate program. This was a key success factor for us. A program driven and directed by data and insight provided us with clear direction of travel for all parties. So that tobacco needs assessment being led by insight and data was crucial for us in terms of our outcomes and our priorities. Establishing a clear and fluid channel of communication between ourselves, Working Well, employers, and our colleagues at CSU Health, and adopting a holistic approach to reaching workplaces that employ our target cohort. So we linked in with our colleagues at Economic Growth by leveraging the impact of the risk factors can have on the cost of productivity. So speaking business language, but using cost of productivity as a way in to those businesses. So I'm now going to pass on to my colleague, Lynn, who's going to touch more on the practical approach and delivery model that was used to the successful delivery of this program.
Thank you, Charles. I'm Lynn Moforth, and I'm the Essex Working Well Manager, and we provide a holistic health and wellbeing support programme for Essex employers. Our service sits within the Essex Wellbeing Service, which is commissioned by Essex County Council. And Provide Community is a community interest company that delivers a range of health, wellbeing and community services. So, as Charles said, I'd like to run through the approach and the delivery model that we applied for the programme. We followed a structured end-to-end approach designed to ensure smooth implementation, strong engagement, and meaningful outcomes for both employers and employees. Once a business was identified, a meeting was arranged to introduce and outline the programme. Following this, an equipment placement agreement and public liability insurance certificate were required to ensure clarity of responsibilities and compliance before placement. We then arranged a site visit to identify a suitable location for placement within the workplace. Promotional materials were then shared with the business prior to install day. During the placement, regular check-ins were sent to employers, providing updates on participation levels. And then during the placement, the team collected the referrals for high BMI, high blood pressure and smoking, and organised the appropriate referrals or contact. Following placement, businesses received a tailored feedback presentation where employees had the opportunity to discuss the support available, to develop tailored, robust wellbeing strategy with the support of the Essex Working Well team. We then sent a post-installation survey, allowing us to capture the longer-term impact on lifestyle change, which informed further enhancement of our offer. If you can move to the next slide for me, please, Charles. Thank you. So, building relationships was a key component. So workplaces were identified through multiple channels, including recommendations from Essex County Council and the Basildon Council Economic Growth teams. We also tried cold calling and attending network events. And the engagement with organisations already enrolled on the Essex Working Well programme also enabled us to enable a fast implementation. Employer engagement was ultimately underpinned by a clear and consistent message that focused on the productivity benefits of a healthier workforce. Post-installation feedback sessions played a key role in strengthening relationships and overall reinforcing the value of continued engagement. Feedback was distilled from the full CSU health report into an 8-page presentational format to quickly deliver those key insights from the data set. And notably, 23% of the new sign-ups to the Essex Working Well programme in 2025-26 occurred following the placement, really highlighting the effectiveness as both a health intervention and an engagement tool. And actually, as of now, that rate has risen to 31%. Employers were provided with a suite of materials, including presentation packs, on-site flyers, and posters. This ensured employees were informed, aware, and encouraged to participate. Clear referral pathways and a defined blood pressure protocol enabled continued follow-up support where needed, some of which was outside of the standard working hours due to the working practices of the users. Participation levels were actively monitored every 2 to 3 days, allowing for timely updates to employers and enabling them to sustain momentum through internal messaging and encouraging that wider involvement. On-site engagement with staff actively encouraged that early uptake, and where appropriate, photographs were captured with consent to support that social media promotion and wider awareness. And then to strengthen the evaluation, the post-installation surveys were conducted with employees. These gathered insight on the ease of using the equipment, whether participation influenced lifestyle or medication changes, and reasons why some individuals chose not to engage. So how did we drive employee uptake? Encouraging employers' uptake was achieved by designing a programme around convenience, accessibility and immediacy. The on-site nature of the service was particularly impactful, eliminating the need for employees to take time out of work to seek support elsewhere. And immediate results provided that instant feedback, increasing engagement and personal relevance, while integration with the CSU Health app enabled those individuals to track and to manage their health beyond that initial check. So overall, the combination of a strong employer relationship, proactive engagement strategies, and a user-centered delivery model created the conditions for participation and that meaningful impact across workplaces. And I'd now like to hand over to Abby.
Thank you, Lynn. I'm Abby Constable, the new Project Support Officer for the Digital Health Check programme. As with any pilot, we did identify a few challenges along the way, but with a fluid approach and close working relationships with all teams, we were able to shape that programme to better meet these challenges. A key barrier to engagement was variable digital and health literacy. So some participants had trouble navigating digital interfaces, understanding health terminology, or interpreting scoring systems. And this occasionally led to partial completion, unnecessary referral requests, or disengagement. So potential issues were flagged with certain cohorts early in the programme, and CSU Health supported simplifying the interface. And then we had additional support in place for some businesses to increase that confidence and completion rates. Concerns about confidentiality and employer access to personal health information reduced openness for some users. And we also experienced a prevailing sort of better not to know attitude towards health. And we observed this among some workers. So if that was all about fear, stigma, or previous negative healthcare experiences. And these factors did initially limit uptake and honest engagement. So new equipment placement agreements and accessible employee resources were developed to improve the understanding of confidentiality, data use, what tests were included in the check, and why these were important. Participation was strongly influenced by employee engagement and environmental factors. So in some organisations, staff were not given protected time to complete the health check, resulting in lower uptake. Placements of machines also affected confidence and visibility. So we found that open locations reduced that perceived privacy, while secluded locations reduced awareness and spontaneous use. And these practical considerations were assessed via a site visit to optimise the user experience and balance privacy with awareness. For example, screens on each station face the wall, and the BP protocol banner could be used effectively to maintain privacy in areas of high footfall. Access to follow-up services also did not match working hours, so we developed a protocol in partnership with Essex County Council and Mid and South Essex ICB to call participants with high or severe blood pressure readings between the hours of 5 p.m. and 7 p.m. And that was to discuss the test results and encourage users to appropriate follow-up care and accessing those pathways. So some of the key lessons that we learned was that digital alone isn't enough. It does need that extra human support in some cases. Workplace setting was also critical for access. Trust and communication was essential. And then again, those follow-up services must match the working patterns. But overall, data was a really powerful tool for targeting some of those interventions. Next slide, please, Charles. Thank you. So guidance screens pre-configured by CSU Health provided a generic health advice during and after completing a health check. And to offer direct signposting and access to local support services, we added an additional consent screen, which allowed users to opt in to be contacted for support from the Essex Wellbeing Service. And this option was triggered when users recorded a high BMI, so that's a 30 or more, and 39% engaged with weight management programme through Essex Wellbeing Service. This consent screen was also triggered when a user recorded that they were a smoker. So we had 30% engage in smoking cessation support via our in-house outreach team in Essex Working Well. And then support was also offered when very high or severe blood pressure readings were recorded. And we had 264 blood pressure support referrals. We also purchased twice weekly referral reports from CSU Health, which allowed for timely follow-up by the relevant teams within 48 hours of a digital health check. Next slide, please, Charles. Thank you. So we've got some case studies to share with you as well. One here is from Richard, who is a street warden at Colchester City Council. And despite having a healthy BMI, he found out that he had high blood pressure and was told that his smoking could also increase his risk of a heart attack. So Richard decided to take the support on offer from Essex Working Well via the Digital Health Check project. And he joined the Swap to Stop scheme to get free support to give up smoking. So Richard actually lost his mother last year in her early 60s from a stroke. And he said he was really grateful that he had the opportunity to use the machine whilst at work, so he could ensure that his children do not have to go through that pain that he has gone through, losing a parent at such a young age. Next slide, please, Charles. Thank you. We also have a case study from Steve, who loads lorries for a company that distribute construction equipment. He had been on blood pressure tablets for 5 years due to kidney issues. He experienced quite rough side effects with these, so he actually chose to stop the medication. And when he used the Sisu Health mini machine, he found out that his blood pressure was extremely high. We were talking about a reading of 210 over 110. But he followed the advice and the protocol. He went to hospital and he was informed by the A&E consultant there that he was in immediate danger of a stroke. So he was, again, really glad to have that opportunity to do his check. I'll now hand back over to Lynn to summarise our key considerations for the project. Thank you.
Thank you, Abby. So what are the key takeaways that we can impart to help you to consider investing in a Sisu digital health check programme? So key one, identifying those key pathways and stakeholders. Who do you need to contact to ensure that you have the right support? We were in an excellent position as we had existing trusting relationships with employers via our Working Well programme and good leads and contacts with Essex County Council and the economic growth teams. That enabled us to launch and deliver at pace. I'm proud of the relationship that we have with Essex County Council and Sisu Health. We've actually worked incredibly closely, which actually is a really essential component of the success of the programme. Then let's think about resourcing. The units do take a lot of management, not just the business mapping, but building those strong, trusting relationships, ensuring the placement documentation pathways are in place and are effective, managing issues, changing placement dates. It all takes time. So my recommendation is to consider utilising those existing services and pathways. So, for example, workplace programmes, NHS health checks, alongside the digital health check programme. And then looking at that data collection. What outcomes do you want? It seems simple, but it's actually essential. And we learned so much during the pilot, and the programme is now naturally more streamlined. To ensure that we're supporting those lifestyle behaviour changes, we are also exploring additional layers of support, including the development of a cholesterol pathway with community pharmacies. To ensure blood pressure literacy, we're looking at that on-screen messaging, and it's been updated to encourage that compliance. And we've developed signposting around the PSS4 results. With the guidance of the Sisu health check team, we were advised to keep that health check as short as possible. And actually 4 to 6 minutes has worked really well for us. And choosing your options specifically to meet your aims. So as Charles has said, we've opted for the PSS4 and QRISK3. But depending on your funding, you may want to gather other information, for example, physical activity levels, alcohol consumption, or other measures. But that evidence really is your key ally. Gather as much as you can. Invest in post-placement feedback. Not everyone will complete it, but it can provide some really valuable feedback and case studies that will help you to further attract funding. And start small and allow for growth in years 2 and 3. And then we're looking at those promotion channels. So we've used LinkedIn, Facebook, economic growth lead promotion to successfully reach those local businesses. We attend networking events with the units, and we found the try before you buy actually can be really effective. And remember, the digital health check is the start of the user journey. The human element is vitally important. So please invest in those robust clinical pathways that provide employers and the individuals with the assurance that users are not left unsupported if they receive a high or a severe result. One of our regular comments is they don't want staff taking time off to go to the GP as a result of the health check. But promoting that lost productivity cost enables employers to think of access to healthcare as a cost saving. And mental health and wellbeing support. As we've said, we opted for the PSS4 stress screening tool. But whether you include that or not, psychological well-being should not be overlooked. The results of the test could impact the individual. Let's not also forget that 1 in 4 adults will have poor mental health. And as we're focusing on routine and manual workers, we needed to raise that mental health literacy by providing awareness and support. So our top tip, sort of with any approach, consider utilising any other existing or new funding to add value to your digital health check programmes. So, for example, Essex Working Well were able to offer on-site men's mental health talks, breathwork and mindfulness sessions through an enhanced mental health contract. And we're also developing a men's self-care toolkit, providing a 45-minute face-to-face session, offering simple stress management tools in workplaces where there is a high PSS4 score prevalence. So thank you for listening. I'm now going to hand you over to Charles to summarise.
Thank you ever so much, Lynn and Abby, for that thorough delivery. So just some final reflections and next steps for me. So we have successfully transitioned from pilot to program, which has included the increase in the number of health check stations that we have available to businesses and workplaces to the optimum number that the program will be able to sustain without compromising the quality of the outcomes and the impact to date. So to date, we've just delivered just short of 5,000 health checks within over 65 plus businesses and workplaces. As Lynn was mentioning earlier, we are also looking at developing clinical pathways such as cholesterol testing. So that has been done via the acquisition of raw data to enhance that the outcomes analysis and to look at different trends. Continued development in the relationships with our colleagues from economic growth, and really integrating CSU and our Essex Working Well activity within both agendas. We are currently working with our internal comms and campaigns colleagues to develop a marketing and communications plan to really raise awareness to businesses about the program offer and to amplify the messages and highlight the unique capabilities, functionalities, accessibility of the CSU digital health check stations, and really to empower employers to support and invest in workplace health initiatives. And I would just say that overall, the pilot has demonstrated for us that delivering preventative health interventions within workplace settings can significantly improve access to health screening for working age populations in Essex. And this approach has enabled the program to engage individuals that are less likely to access to the traditional primary care services, particularly those in routine and manual occupations and those working outside standard office hours, alongside younger individuals who may not routinely engage in health services. The CSU Digital Health Checks program provides a scalable, data-driven approach to workplace prevention and continued partnership work in sustainable staffing models and service adaptation informed by the learning. The program has a strong potential to reduce inequalities, improve workplace well-being, and support a healthier and more productive Essex workforce. So I'm just going to pass back to Jez for any closing remarks and also to facilitate the Q&A. Thank you.
I was just about to start off actually with personal story, which is a little bit unscripted, but listening to Charles and Abby and Lynn, it's been quite inspirational for me, really. So my father actually lives in Essex and in Basildon, or close to Basildon, which is where one of the initial parts of the pilot started. He suffered a stroke about 30 years ago and basically had sky-high blood pressure. He wasn't in a manual routine workplace as a journalist. He just was too busy to go and get a health check. And I often think back to had there been access to a CC health station, had he been alerted to the fact that his blood pressure was high as it was, it would have avoided the stroke. And as we all know, and the CBD framework, which was released last week, talks about the fact that, you know, leads on to multiple long-term conditions. And he's gone on to be resuscitated at Basildon Hospital several times over, multiple operations. He's probably cost the NHS many hundreds of thousands of pounds. And I often think, if this Essex pilot had been in place 30 years ago, it would have been very, very different. So I'm so pleased that this is going on. So thank you to the Essex team. So I'm just going to close off with a few slides, just talking about the sort of the data from CSU as a whole and what we do elsewhere. So we have completed around 700,000 health checks in over 2,500 workplaces, mostly across the UK, but we have also expanded into Europe over the last 2 years through some of the employees we work with, such as Jaguar Land Rover and Workday and a few others. And that's everything from working with banks in the city right through to meat processing plants in the Fens. And we talked about a project that we did with Cambridgeshire Council earlier in the year. And we've also completed around 718,000 health checks in public spaces where we do a lot of our work. And that's working with a lot of different public health teams around the country, delivering in supermarkets, places of worship, libraries, festivals, and all sorts of other interesting locations as well. I guess what's really, really important is that the workplaces does deliver a different experience, a different data set, and we do see a different change in behaviours as well. I guess the key thing really with that is the fact that we're attracting or targeting people in the places where they already are. One of the things that we do as an organisation is look at the COM-B model to make sure that we're underpinning all of our thinking with a really effective way of managing the model. And obviously that looks at capability, opportunity and motivation to drive behaviour. And as we know, with prevention, opportunity, not motivation, is usually the binding constraint. So our belief is that we should create easy, visible opportunity in everyday settings. That drives engagement, builds capability, that then goes on to drive motivation and action. And at scale, that leads to a population level impact. And the next slide actually just brings that to life a little bit more as well. So as I said just a moment ago, we've completed 700,000 health checks in workplaces, and we've also launched a user survey. It goes out to users after 48 hours after a health check, and then 12 weeks later to look at whether there's been some sustained behaviour change. And in terms of opportunity, we reach a really important cohort in workplaces. So 60% of that 700,000 health checks has been with men. That's a median age of 38 and a median deprivation decile of 5. And it's typically the working age higher risk population that traditional services struggle to engage. And obviously just shared my own personal experience, and I know lots of other people have similar. Nationally, we see around 65% of employees haven't had a blood pressure check in the past year, and the CC platform offers access around the clock. So we see huge numbers of people doing health checks outside of GP opening hours. Essex, obviously, the team shared a moment ago what they've experienced themselves. In terms of impact on capability and motivation, 73% of users tell us that the check influenced their health decisions within 48 hours. While 1 in 3 were showing a risk that they didn't know they had. And the workplace effect is really impactful. Men make up 60%, as I just mentioned, versus 47% that we typically see in community settings. And 78% of individuals act on the health results. and that's men specifically versus 72% elsewhere. So doing a health check in the workplace really does drive additional levels of behaviour change. The surveys that we've delivered after 12 weeks give a really compelling story. We're seeing 89% of individuals reporting healthier choices, and that's with improved diet and improved activity levels. We're seeing blood pressure drop by around 26%, smoking down by 20%, and we get really strong net promoter scores. So people score their experience at the end of the health check, and they tell us what their thoughts are. And often what we really see is that the strongest NPS scores come from people in IMDs 1 and 2, and also specifically from the Black community as well. So we can create that opportunity and capability, then motivation and behaviour change will follow. So just a quick note on the Core 20+5. So we talked about over half of the users come from the most deprived IMD areas. The Essex team talked about the routine and manual workers with 3 times the smoking prevalence and a 5.5-year life expectancy gap. We're seeing really strong engagement there. The impact is equity positive. So 85% of Black and 82% of Asian users say the check influenced their decisions versus 70% of white users. And we're seeing really strong results from the hypertension case finding and smoking, specifically for the Core 20+ community. And this directly connects to the CVD Modern Service Framework, which was published last week, which has really taken quite a big focus on community-based blood pressure case finding. We, as a business, have generated over 128,000 GP calls to action with that specifically in mind. And just on to final part, really, just talking about the employers, because as the team have alluded to, it's not always easy to engage, and we directly engage with employers ourselves through other work that we do, and also with some other projects with other local authorities. And we often hear the story that a lot of employers will say, we don't want to take people off the production line. It's going to take too long, 30 minutes to do a full NHS health check as an example, to tend to push back on. Because of the shortness of the health check, the 5 to 6 minutes, it often will drive additional desire, I guess, to go ahead. And a piece of work that we did in Cambridgeshire found that actually the local authority was able to drive more initiatives into the workplaces. I talked about the meat processing. There's a lot of quite tricky workplaces where we would have failed to engage with previously. So we provide industry benchmarking. It really does engage the employers. Some really, really interesting data. And again, be very happy to share a little bit more about that a little bit later or another day. So I'm going to move on to our Q&A shortly. We are going to be releasing a health economics report towards the end of the summer. If anyone is interested in learning a little bit more about that, I'd be very happy to share that with people directly, and please feel free to contact me. So I can see there's quite a few questions in the chat. So I'm going to start picking a few out, and it will be, I'm just going to work through here. So just a quick question, I think, about the employer engagement. So one of the questions was, how did you map and identify manual and routine work businesses? I'm sure if Charles or Lynn who would like to take that one.
Are you happy for me to take that one, Charles?
Yes, I'm happy for you to take that one in terms of delivery, Lynn.
But please dip in. So as we said, I mean, we were working with Essex County Council and the Basildon Economic Growth team. So they provided us with a number of key workplaces. We also had the workplaces that were currently signed up to Essex Working Well. Again, it was that promotion, and a lot of the times it was cold calling, looking at those particular sectors that we knew would have a high routine and manual prevalence. So I think we've now worked with every bin depot across Essex County Council. We've worked with logistics, we've worked with manufacturing. So it was really identifying those key groups. And sometimes it would take a while to build that relationship to be able to place it. So I hope that's answered your question, or Charles or Abby, if you want to add anything to that.
Yeah, I'll just add to that also the existing relationships. Once a placement was successful, that domino effect of other business, the existing businesses referring on to other businesses also played a part as well in further placements going forward.
Brilliant. Thank you both. So the next question was, is there any data or evaluation to show how many people went on to access further support from local services? I think you touched on that earlier, but is there anything else you'd like to expand on with that question?
Yeah, I'm happy to add the first part to that. So, of course, we've set up the pathway in terms of blood pressure support, and also in terms of linking into our Essex Wellbeing Service for stop smoking and weight management. And some of those case studies that you also saw as well, there are a proportion of businesses and employees that we're identifying as champions as such, so that we can follow them on a longer journey for harder outcomes, so we can revisit them in maybe 18 months to see the differentiation in terms of whether it's their BMI or their blood pressure later on down the line. So that's what I will add to that part. I'm happy for you to add anything further in.
No, I think you probably covered. I think you covered everything there. We obviously have the report at the end. So, and again, when we're making those phone calls for people who have the high BP, they're often giving us the feedback that they've gone away. They've either retested, they've checked their blood pressure, or they've gone to the GP. But again, we'll get data from that post-placement feedback report as well. But generally, the outcomes have been that people have, if they have been encouraged to access GPs, they have accessed that support.
Brilliant. Thank you, Lynn. So just a quick question around how measured the change in lifestyle, diet, physical activity, etc., and how that's been followed up. So obviously we have the CCU survey that goes out to users, and you've kind of alluded to, Lynn, there in a couple of answers around the follow-up with those users. What else, I guess, what have you done? Any recommendations for what other people could do?
I think that sort of, having those conversations with people and having that post-placement sort of feedback session with the employers, because then we're going in and we're looking at, helping them to develop, a health and wellbeing strategy. So it's not the workplace is actually changing that culture around health is important. But again, the individuals are getting those messages. As well. But certainly, as we've shared with the case studies, we can see that people are listening, and sometimes people have to be told several times before they're ready to make that change. But certainly all the evidence we've had is people have taken notice of the check.
Brilliant.
Abby, do you want to add anything there?
No, I think you've covered a lot. I think the post-install feedback surveys that we send out, so once we've compiled that feedback presentation and we invite the employer to have a meeting to actually present and go through that, we're also asking them to send out that survey, aren't we? So we've got a few good snippets of information come through about whether people have followed up, what kind of lifestyle changes they've made, and like Lynn reflected earlier, whether that's been in result of any kind of medication changes. We had one case study from a lady as well, didn't we, who worked at a call centre, for example, and she actually had a lot going on in her life in terms of juggling children and work. She actually used the Mini in her lunch break, and so in 5 minutes, again, she found out her blood pressure was really high. She had a high BMI, so she actually sought the support, got on some tablets. She's started Couch to 5K. She informed us that she was eating more vegetables, and she was really pleased that her company had, the opportunity to use that machine. So we're getting snippets of things like that from the surveys themselves, and people are happy to share their stories. We've got quite a few different case studies, which of course we couldn't share them all with you today, but we've got plenty of stories like that. So that's a nice way to capture.
Brilliant. Thank you, Abby. I've got
there's just a question from Rachel Johnson, if you don't mind. I wanted to answer around high blood pressure. Is that okay?
Of course, absolutely.
Fantastic. Yeah, so Rachel was mentioned, rightly so, that high blood pressure needs to be confirmed. So consistent monitoring of the following the initial reading. So a key success factor for us, when we were launching the program, was to get our clinical leads on board within the ICB, working closely with the GPs in primary care, and we actually set up a blood pressure protocol so that primary care would not be overwhelmed with a sudden rush of high blood pressure readings coming via a CSU health check. So as Abby rightly mentioned, when a user recorded very high or severe readings, this triggered, if they consented, this triggered a call between 5 to 7 p.m. But overall, we also placed banners alongside the CSU health check. You would have seen in that case study, there was a photo that there was a banner there that really gives guidance and advice around what to do with your results. Coinciding with that, alongside the pilot, in September 2025, we actually launched our county-wide blood pressure monitor library loan scheme. So we were able to signpost and direct users that needed to monitor their blood pressure. So if they got a very high reading over the next 2 weeks, for clinical review if required. So I just wanted to add that yes, that relationship between primary care and not overwhelming them was crucial for us, and in terms of that sustainable model of monitoring blood pressure.
Brilliant, thank you, Charles. And there's a really couple of people similar sort of question, really interesting one, which is, were there any unintended learning or outcomes from the pilot, or indeed subsequently?
I would say, of course, that we're currently booked to the end of the year. So in terms of coordination, we're of course we're delighted. We were not sure in terms of how it would be, if we would have to really struggle or try to really extend ourselves to have businesses buy into the program, of course, and the marketing and communications plan has really played a key part in that. I did see in the chat there was a question around unintended consequences in terms of business employees or staff having to take time off. I'm not sure if that's the case. However, we are empowering businesses to be to really contribute to their workplace health. So and look at in terms of absenteeism and presenteeism. So if a employee does have to take a couple of days off, looking at the wider impact, if it was due to have a health check or to follow up on the advice of the health check, rather than a sudden event that's taken place, that would be a longer period of time, potentially a longer period of time. So we're looking to change the perspective of how employers look at their staff having to take time off for health and well-being.
Brilliant, thank you, Charles.
If I could just add to that as well, we've had so many conversations with people who, and we had one quite recently where someone felt unwell at work, and they had the mini station sort of placed, and the manager said, well, why don't you just hop on and just do the check, and the individual had incredibly severe blood pressure, so they booked a taxi and took the person to A&E. That person was assessed and was given medication, and actually they were back in work the following day. So I think it's the opposite. If someone does need to go and seek that help, the fact that they can be, with the right medication and support, they can be back in, or safely back in work, and carrying on. So I would say it's the opposite way. It's the opposite way round, and that loss of productivity data that we're able to provide does make people realise that if someone carries on working, and they've got a significant risk of having a cardiovascular event in the next 12 months, they will be out of work for probably 3 months at the very least, and then may not even be able to return to their original substantive role because of the impact. So I would
Thank you,
say,
Lynn.
yeah.
Thanks, Lynn. Sorry, we are time is up, and what a great note to finish on. So, just for everyone's awareness, we will send out a link to a recording of the webinar. I think it's most likely to go out either later this afternoon or tomorrow. And there is an evaluation report available and some other documentation. Please feel free to reach out to us if you'd like any further information, and hopefully look forward to seeing you on next webinar, which will be scheduled for September. Thank you all.